Morning and welcome to the 24th meeting of the Health and Sport Committee in 2020. We have received apologies this morning from Alex Cole-Hamilton. First item on our agenda today is consideration of 4 consent notifications proposing that the Scottish Government give consent to the UK Government to legislate using the powers in the European Union Withdrawal Act in relation to a number of UK statutory instruments. The first consent notification we will consider is in relation to the reciprocal and cross-border healthcare amendment, etc., EU Exit Regulations 2020. Can I invite comments from members? I see Sandra White.
Thank you very much, Convener, and good morning. It's page 4 of the report. It's actually under recommendations, where it mentions about the letter confirming approval to request that the Scottish Government is kept updated on the Government's role in negotiations as detailed above. I just wanted to point out paragraph 19, where it mentions the fact that we may wish to use a letter which is in the recommendations to make sure that the Scottish Government's role in negotiations between the UK and the EU on the future status of citizens' rights to healthcare and social security benefits. And in particular, the committee could ask what progress is being made in relation to the rights of Scottish citizens and what rights they'll have if they fall ill while travelling, living and working abroad in the EU after the 31st of December. I just think it's an important paragraph to raise, and I would certainly say that 20B, using that letter to confirm the approval to request, I think that's really important that we do that and keep an eye on this particular part of that.
Thank you very much. I see no other members on this particular regulation, and as Sandra White has described, we can use the letter confirming our approval if we are content to ask to be kept up to date on the Scottish Government's role in these negotiations. Are members content that the Scottish Government gives consent for UK ministers to lay a statutory instrument in the UK Parliament on this subject, and that we use the letter in the way that has been described? That is agreed. Thank you very much. The second consent notification we will consider is in relation to the Nutrition Amendment, etc., EU Regulations, EU Exit Regulations 2020. Again, can I invite any comments from members? If there are no comments on this regulation, are members content for the Scottish Government to give its consent for UK ministers? My apologies. I missed you there.
Thank you, Chair. Yes, I mean this touches on the Northern Ireland Protocol, and I just wanted some clarification in regards to a number of issues which I think have been raised in this respect. Is the Northern Ireland Protocol deemed to be with the EU regulations? Because obviously all the way through this, it mentions taking out Northern Ireland and taking out the UK and putting in Great Britain. My reading of a number of, I don't want to go on too long, I could go through all the different paragraphs, but my reading of it appears to be that the Northern Ireland Protocol is more akin to the EU Protocol, and that's why Northern Ireland is taken out of these SSIs. Is that correct in that respect, Convener?
Yes, the regulation is in fact, I think it's the following regulation on human tissue, which we'll come to in a moment, which has more focus on the Northern Ireland Protocol. What that does is put in place, and all these regulations, in summary, put in place the arrangements under the withdrawal agreement, in other words, under the treaty agreed between the United Kingdom and the European Union, which allows Northern Ireland to continue to operate within the scope of EU regulations, and therefore it does require a slightly different approach between Northern Ireland and Great Britain in relation to these matters. Pardon me. Yeah.
Yeah, sorry. It's just in the letter from the Cabinet Secretary, basically obviously mentions about Cabinet Secretary Mike Russell writing about these regulations, and it mentions in it, it is our unwelcome responsibility to ensure that devolved law continues to function, and attaches the regulations, but it also says, please note, this is the Scottish Government, please note we are yet to have sight of the final SI and is not available in the public domain at this stage. So I'm a wee bit concerned that we haven't seen this SI, and obviously we're recommending, as is the Scottish Government, that we have no option or choice but to put this through. And that's another issue that I wanted to raise as well in regards to that. And the last issue I'll raise, rather than go through all the various paragraphs, is the situation where, as you have clarified for me, thank you, that Northern Ireland actually rules and regulations are more akin to the EU. That's why they're taken out of this, which is rather strange when it's supposed to be part of the UK. But does that mean, and I think it will come into the organ transplant and tissue, etc., does that mean that regulations, if any goods are coming from Northern Ireland to Great Britain, as it mentions here, they are just treated as imports? But if any goods are being taken from Scotland, or the GB as it's called, over to Northern Ireland, then that means that that is subject to EU law in regards to the fact that it's not treated as imports. Is that correct?
I think broadly that describes the position. It is a complex position, as you say. What I think the reference to sight of the draft statutory instrument is an important reference. And what I was proposing to recommend to the committee was that we agreed to the Scottish Government going ahead on the nutrition regulation, but do so, but in writing, that we would express that we would welcome sight of the draft SI once it is available to the Scottish Government. That clearly is going to be a common experience, as it has been already in the whole process of EU exit and withdrawal legislation, because some of this is being done at a pace that means that the drafts are not seen always in line with the usual parliamentary requirements. But what you've described in terms of the relationship between Northern Ireland, Great Britain and the European.
Thank you for that. And I presume that that's to stop a hard border between Northern Ireland and ERA. I presume that's the reason for it, which with Brexit looming, I think is very important that should be mentioned. But thank you for the clarification. Thank you.
That's exactly correct. Excellent. I hope that does clarify matters. As I say, some of the issues that Sandra raises have perhaps greater applicability on the next instrument to which we'll come. But in the meantime, in relation to this instrument, which is the Nutrition Amendment EU Exit Regulations 2020, our committee members contend for the Scottish Government to give its consent for UK ministers to lay an SI in the UK Parliament on this subject, and to confirm, in confirming approval, to welcome sight of the draft SI when that is available. I see agreement around the committee. Thank you for that. We will then move on to the third consent notification. This is in relation to two instruments: the Human Tissue Quality and Safety for Human Application Amendment EU Exit Regulations 2020, the Quality and Safety of Organs Intended for Transplantation Amendment EU Exit Regulations 2020, and indeed a third one, the Blood Safety and Quality Amendment EU Exit Regulations 2020. So three instruments, but all under the terms of one consent notification. Can I invite comments from members? And I see Emma Harper.
Thank you, Convener. Good morning to everybody. So I just want to clarify that in paragraph 3 of our papers, it says the effect of the amendments will be that where donated human organs, tissues and cells and blood move from Northern Ireland to Great Britain, they will not be treated as imports. Conversely, however, these are sent from Great Britain to Northern Ireland. They will need to be treated as imports. It's disappointing, obviously, that we're leaving the EU, and I just worry that this is going to increase complexity, because as a former liver transplant nurse myself, I worry that delays will be incurred, and we can't have delays in organ and tissue transplantation. A heart can only stay on ice for 4 hours. It's a real challenge. We need to make sure that no delays are incurred by any of these regulations that are now put in place. I'd like to seek assurance about that.
I think that's very reasonable. And I also see Brian Whittle.
Thank you, Convener. Just clarification around this particular bill. It's my understanding that one of the reasons that there is this potential for a disparity there is because of the devolved nature of health within the UK and the difference between the UK and Northern Ireland. I just wanted to clarify: is that one of the reasons why there seems to be a one-way decision here?
I think I'm no expert on the details of these matters, but my sense is that no, it's not particularly that. I think the same the regulation we're considering today in the context of Scotland is a variant of the same regulation that will apply in the context of England, and the definition is between, or the difference in definitions between Great Britain on the one hand and Northern Ireland on the other, and that, as Emma described, is fundamentally in order to protect the position of Northern Ireland and access for Northern Irish citizens.
Okay, so just to clarify, sorry, yeah. So as it currently stands, we have obviously we the committee we have looked at organ donation, and the Scottish Government and the Parliament have changed the way in which we can access the transplants. As it currently stands, it can move. Transplants can happen, or transplant organs can move around Great Britain freely, as we currently stand. Is that changing now with Northern Ireland? Is that what we're saying?
No, but what it does, it creates a framework within which change could happen in due course. And clearly that would be a concern in the way that Emma Harper has described if it had consequences for the transplant process, either in Northern Ireland or in Scotland or elsewhere in GB. So I think, again, it's something I would suggest in conclusion that we address in looking at this instrument. I also see Sandra White.
Thank you, Convener. I didn't think it was in. The clarification that I received earlier, and Emma's point is very, very valid, is, as far as I know, NIP, or as it's called, Northern Ireland Protocol, it's a protocol for them alone, and it's more akin to European law, and that's the reason that this is all being changed from UK to Great Britain, and it mentions specifically England, Scotland and Wales. And it also mentions specifically that any organ transplant from the UK, or GB as they call it, will be subject to EU protocol. And when Northern Ireland bringing transplant or organ donations over to the Great Britain side, that will just be treated as an import. So I think there's implications here, not just about the length of time, but is there any charges or anything like that? And that's my understanding of it. Because simply it's because of Brexit, and to make sure there's no hard border in Ireland. I think that's what it's all about.
I think that's absolutely right. I think that describes it well. And we are in very unusual circumstances. My reading of it is that the government, both the Scottish Government in particular, in bringing forward this instrument, is seeking to protect the position of those who may wish to receive or indeed to donate in relation to transplants as between Scotland and Northern Ireland. The wider treaty between the UK and the EU protects Northern Ireland's access or membership, if you like, subjection to the rules of the single market. And that's a political agreement that's been reached between the UK and the European Union. It is, to go back to Brian's point, it is of course perfectly possible that we could end up in a position where there are 4 different sets of regulations applying across the 4 nations of the United Kingdom. That is a possibility. I think Emma Harper wanted to come back in briefly on this one. Emma Harper.
Thanks, Convener. It's just to raise a point about organ and tissue transplantation, the traceability and the tracking and the following of organs and tissues is absolutely crucial when we are working with patients and trying to make sure that the right organ gets to the right person, and that then we can trace all that as well. So I'm concerned that that Brexit isn't just a job done. It's caused so many issues that we need to make sure that safety of everybody involved is continued when we look at changing these regulations.
I think that's certainly my view, and I think from comments from Sandra and Brian, I think it's also the priority of the committee to protect the organ donation provision that the committee did significant amount of work on over the last year or two, and to ensure traceability, for example, is maintained, and that as much freedom of movement of organs in these vital and time-dependent circumstances maintained as possible. I think then what I would suggest now, that if there are no other comments from members, I think while clearly this is a matter of great concern to the committee, I don't think I've heard anyone suggest we should not signal our approval of the Scottish Government proceeding. That would be to give consent to UK ministers laying an SI in the UK Parliament on this subject. Are members of the committee content with that, subject to a letter asking for confirmation on a number of the issues? If members are content, I would suggest that the letter should include a request that we're kept up to date with on the Scottish Government's engagement with the UK Government on the Northern Ireland Protocol, to ask what procedure would apply if there was to be divergence in the applicable standards between Northern Ireland and Great Britain in future, and to ask for an assurance that the Scottish Government is approaching this matter in a way that will ensure there is no delay in the matter of organ transplantation and no impact on traceability in the matter of organ transplant. Are those points to go in the letter agreed by members? We're all content. Thank you very much. The fourth and final consent notification in relation to these matters is, in this case, it is two regulations. It's the European Qualifications, Health and Social Care Professions, EFTA States Amendment, etc., EU Regulations 2020, and the Professional Qualifications and Services Amendments and Miscellaneous Provisions, EU Exit Regulations 2020. Again, both under one consent notification. Are there any comments from members on this matter? If not, can we agree, is the committee content for the Scottish Government to give its consent to UK ministers laying a statutory instrument in the UK Parliament on this subject? Does that meet with the approval of the committee? That is agreed. Thank you very much. That concludes that agenda item. We now move on to agenda item number 2, coordinate legislation, consideration of 2 made affirmative instruments. As in previous weeks, these relate to coronavirus and international travel and are laid under Section 941, International Travel of the Public Health, etc. Scotland Act 2008. These regulations should be subject to the affirmative procedure, but where they need to be made urgently, they can be made by Scottish ministers, but must then be brought before the Scottish Parliament within a period of 28 days, beginning with the date in which the regulations were made. And it is for the Health and Sport Committee to consider these instruments and report to Parliament accordingly within that 28-day window. We have once again in front of us the Cabinet Secretary, whom I will welcome in a moment, but the instruments we are looking at today are the Health Protection Coronavirus International Travel Scotland Amendment Regulations 2020 number 13 and the Health Protection Coronavirus International Travel Scotland Amendments Regulations 2020 number 14. Welcome to the committee the Cabinet Secretary, Humza Yousaf, who is accompanied once again by Rachel Sunderland, Deputy Director for Population and Migration Division, Damien McDougall, Deputy Director of the Test and Protect Portfolio, and Anita Poppleston, Head of Police Complaints and Scrutiny. I would propose once again, with the agreement of members and of course of the Cabinet Secretary, that we take these two items, these two regulations as one, and that will involve any questions to the Cabinet Secretary dealing with both regulations, and then moving on to the formal debate again on both together, if that is agreeable to members. Can I start with a first question to the Cabinet Secretary, and I'll then invite any members who have other questions to come in on them. I think when we last had the Cabinet Secretary in front of us, we talked about the question of a publication of numbers and increasing transparency on the quarantine regulations and their application and enforcement. I wonder if the Cabinet Secretary has anything additional he would wish to draw to our attention today in that regard. Cabinet Secretary.
Good morning, Convener, to you and to the rest of the committee. I hope all of you are keeping well and safe. I do thank you for asking the question, Convener. If you hadn't, I would have proactively mentioned the fact that in previous committee sessions, I've referenced the fact that the numbers of people who have tested positive, who have a link to international travel, would be published by Public Health Scotland on the 23rd, i.e. tomorrow, 23rd of September. I've been given a note today, this morning, and I'm more than happy to expand on it in writing, that has been delayed. It shouldn't be a long delay, but there has been some concerns from Public Health Scotland around the quality of the data and some assurance work that they need to do around that. So as I say, I've been told that they're working to resolve the issue so that these numbers can be published, and there'll be a call between officials and Public Health Scotland to get into the detail of that. So at the moment, yes, the intention is absolutely to publish those figures. It won't be tomorrow, as I previously indicated, but I've been told the delay won't be a long one. So my apologies for that. Of course, I'd like to have been able to have those figures to hand on the 23rd, but they will be delayed.
Thank you for that. It's clearly disappointing that there is a delay, but it's good to have your assurance. I also have a question from Emma Harper.
Thank you, Convener. Good morning, Cabinet Secretary. Just a quick question. It's been brought to me by constituents that people travelling into Scotland, should they be accessing or downloading the Scotland Protect app as well? Is it possible that can the Scottish Government help me shed some light on that, please? And are we encouraging people to download the app?
Cabinet Secretary.
Yes is the short answer. If you download the app, yes is the short answer. If you download the app, you put on the Bluetooth function, as you know, it'll let you know, and your location function, of course, it'll let you know who you may or may not have been in contact with. So even if you're in the country for a few days, for a week, for 2 weeks, holidaying here, then it's absolutely advisable. Emma Harper makes a really good point that she alludes to, that perhaps, if you don't mind, I'll take this away with health colleagues to look at whether we can do more at the ports of entry to ensure people know to download the app. So I know we have an advertising campaign around the Test and Protect app, but let me just double check with my colleague, not just the Health Secretary, but obviously the Transport Secretary, around whether we need to do more at the ports of entry. I think it's a really good point.
Thank you very much. I see no further questions from colleagues, in which case we can move on to the next agenda item, which is in relation to the formal debates on these instruments. As I said a moment ago, I propose to take the two instruments together. Our members agreed that we should do so. I see agreement to that we should do so. In that case, I remind members this is a formal debate, and it will be there will no longer be questions, but there may of course be contributions. And can I invite the Cabinet Secretary to speak to and move the motions S5M 22634 and S5M 22705 in his own name. Cabinet Secretary.
Convener, as previous weeks, I know how packed your agenda is, so I'm happy to waive my right to speak to the regulations and simply move motions S5M 22634 and S5M 22705, both in my name.
Thank you very much. Can I ask if any members wish to contribute to debate on these instruments? If not, we will move to a single question on these two motions. The question is that motions S5M 22634 and S5M 22705 be approved. Are we all agreed? We are agreed. Thank you very much, and we will report to Parliament. I thank the Cabinet Secretary and his officials for their attendance today and for once again being available to answer questions on these regulations. I have no doubt we will see them all again before too long. This is an ever-changing scene, and no doubt we will hear more as we go forward. Thank you very much, Cabinet Secretary. We now move on to the fifth item on our agenda, which is an evidence session on the budget 2021-2022. Our approach to scrutiny of the budget reflects the approach recommended by the Budget Process Review Group. We have undertaken evidence sessions with a number of interested parties involved in the health and sport budget, and today we are hearing from the Scottish Government, and I am therefore happy to welcome to the committee, on behalf of the Scottish Government, Joe Fitzpatrick, Minister for Public Health, Sport and Wellbeing, and Richard McCallum, Interim Director of Health, Finance and Government at the Scottish Government. And can I invite the Minister to make a brief opening statement? Joe Fitzpatrick.
Thank you, Convener, and good morning, Committee. Can I first thank the Committee for its forbearance in changes to this session. Clearly, these are fast-moving times, and I'm sure the Committee is aware that the Cabinet Secretary is otherwise engaged. But for the record, for our COBRA meeting over the weekend, yesterday afternoon, this was confirmed for this morning. It will be followed by a meeting of the Scottish Government's Cabinet to confirm our response to the current coronavirus developments in advance of the First Minister's statement to Parliament this afternoon, subject, of course, to the agreement of the Parliamentary Bureau, which I think is meeting around noon. So I'm pleased to be able to stand in for the Cabinet Secretary and would like to take a few moments to set out some reflections on the health and social care response to COVID-19. I will outline for you the key considerations that have underpinned our approach so far, and in view of the primary concern of the Committee for this evidence session, I will also highlight the high standards of stewardship that we have maintained throughout. The Committee will be well aware of the scale of the challenge across our public services and the level of uncertainty that we have faced. In this context, it gives me particular pride this morning to reflect on the ways in which our frontline NHS and social care workforce and all those working to support them have responded so heroically throughout the pandemic, and we owe them a significant debt of gratitude. In terms of key developments over the last few months, and with NHS 24 as the key point of contact, Community Hub and Assessment Centres have provided wide-scale triage of patients with symptoms away from GP practices and out of our services towards assessment centres established exclusively to respond to patients with expected COVID-19. Between the 23rd of March and 2nd of September, around 115,000 individuals have been seen, with more than 140,000 consultations through the community hubs and assessment centres. Developed our digital solutions, such as Near Me video consulting service, where we condensed what we'd been planning as a 2-year programme of change into just 6 weeks. Near Me is now embedded in the way a large number of services provide patient-centred care and will have long-lasting benefits beyond COVID, reducing the need to travel and take time off work for appointments. Between the 1st of March and the 8th of September, over 297 million items of PPE were delivered to hospitals across Scotland. In addition, 129 million items were distributed to social care organisations and 41 million for community care. We're now undertaking detailed winter planning to ensure supply meets demand. And to support these necessary decisions on COVID-19, we immediately put in place arrangements across NHS boards, integration authorities and at the Scottish Government to ensure tight control of spend and to maintain the highest standards of stewardship. This includes implementing a revised framework for rapid and effective decision making across the sector, while continuing to ensure overall ministerial responsibility. Officials are currently concluding our detailed Q1 review of expenditure, and once we have had the opportunity to review this in detail, we will provide further funding across the sector, both for costs incurred to date and to support ongoing activity and remobilisation over the coming months. We'll be happy to share further details with the committee in due course. As we now look to the months and years ahead, we are taking forward initiatives to continue to develop a world-class public health service that builds on our COVID-19 response. In the programme for government, the most significant economic and social policy of this coming parliamentary year will be our commitment to testing, contact tracing, surveillance and response. As the First Minister has set out, central to that will be continuing to suppress the virus, building upon the early success of our work on surveillance response and NHS Test and Protect as we continue to remobilise the health service. This will be supported by our new proximity tracing app, Protect Scotland. In terms of preparing for winter pressures, to protect people and our NHS this winter, we will be extending the seasonal flu vaccine to those working in social care who provide direct personal care, those over 55, those living with someone who is in the shielding group, and depending on vaccine supplies, those aged 50 to 54. That's obviously in addition to the existing cohorts who would ordinarily have been given the flu vaccine. Also, as set out in the programme for government, we'll establish community health and wellbeing services that will support children, young people and their families, and have a particular focus on mental health across all local authorities in 2021. We'll work with boards to retain, develop and support mental health assessment centres as part of a broader approach to improving access to appropriate help as quickly as possible for people with mental health needs or distress. Alongside our investment in mental health, we will continue our work to deliver our priorities for social care and primary care reforms, shifting the overall balance of care towards community health services. And obviously I'd be happy to discuss any of these areas with the committee. Thank you, Convener.
Thank you very much. And I should also put in record the committee are very grateful to Mr. Patrick for stepping in at short notice to take the place of the Cabinet Secretary. We have a lot of territory to cover this morning, and I know he will be keen to address the questions that members raise. And so, without further ado, if I can bring the focus firmly onto the budgetary aspects of these matters and ask, in relation to the current financial year, what additional sums are expected to be allocated to the health budget over and above the 620 million identified in the summer budget revision? And does the Scottish Government plan to allocate additional resources beyond those received in health-related Barnett consequentials? Mr. Fitzpatrick.
So in terms of additional resources, members will be aware that the autumn budget revision is due to be published on Thursday of this week, the 24th of September, and I can reveal to the committee that that will confirm £2.5 billion of additional health and social care consequentials for the health portfolio. Clearly, in terms of additional resources over and above, clearly there are significant uncertainties in the forecast from NHS boards and IGBs, in particular in terms of the implications of winter, a second wave, PPE, social care. So there's a huge amount of work that is progressing at pace to continue our assessment of financial implications to ensure that we continue to provide the necessary funding for our frontline health care services.
Clearly, one of the consequences, and no doubt we'll hear more about that work in due course, one of the consequences of the COVID crisis has been less activity in other areas of health and care, inevitably so, as resources have been targeted on the most immediate and urgent priorities. I wonder if the Minister could offer any estimate of how much may have been redirected from elsewhere in the health budget as a result of those reduced levels, and if so, how much might be and from where, Minister?
Clearly, that's obviously one of the unfortunate things of COVID, is some of the work that we would have hoped could progress has had to be paused, and so we would expect boards to have a level of savings as a result of activity not taken forward. But that's something that we're still currently working through with boards in advance of agreeing funding for over the winter period. So I think it would probably be too much of a guess if I was to give you any sort of a figure.
Thank you very much. Looking beyond the winter period and the current financial year, COVID-19 will clearly have implications for the budget for 2021-2022, which fundamentally is the objective of our pre-budget scrutiny, is to consider that year's budget in addition to this. And I wonder if the government has yet come to any view as to what additional resources will be required, and if so, to what extent that might be, Minister.
Obviously, one of the big parts of the jigsaw is UK funding, and that's obviously not being confirmed beyond this year, and that's an essential part of the picture that we would require going forward. But we do expect the Chancellor to deliver on his commitment in full, that the NHS will receive whatever funding it requires. In terms of implications for the 21-22 budget, there will need to be an assessment of the recurring implications of spend that's been committed this year. So, for example, additional packages of community care, additional hospital beds, community hubs, IT investment. So we need to understand what will be recurring and what has been one-off. So there's a huge amount of work going on to assess details with NHS boards, with the IJBs, and that will help us form a clearer picture of what support is required going forward.
Thank you very much. And now call Emma Harper.
Convener, good morning, Minister. I've got a couple of questions about NHS board mobilisation and remobilisation plans. We know at the start of the pandemic, health boards, in conjunction with their health and social care partnerships, were asked to submit COVID-19 mobilisation plans to the Scottish Government, outlining actions requiring to address their plans for mobilisation, and now we have remobilisation as well. So I'm interested on the basis of the mobilisation and remobilisation plans submitted by the boards, what are the total additional resources estimated to be required by health boards and health and social care partnerships for Q1 of 2021 and then for 2021 as a whole?
So, sorry, taking the second part of your question first, clearly there's a lot of work still to be worked through, and so there's a whole load of planning ongoing in relation to second wave planning and other factors. So in terms of the longer term, that's difficult, but clearly we have a clearer picture in relation to the Q1. So we anticipate something just under £500 million for all health boards and integrated authorities for that first quarter of 2021. So but the longer picture, I think it is difficult for us to estimate at this stage.
Emma Harper.
Are net consequentials sufficient to cover the additional expenditure expected to be incurred? And if not, how will any gap be funded?
Minister.
Well, we're all working to work within the envelopes that we have, and that's the starting point. But there remains significant uncertainties in the forecasts from NHS boards and IJBs, particularly in terms of PPE spending, testing, remobilisation, and of course the implications of winter and the potential for that second wave, if it comes or doesn't come, how it comes. There remains a lot of uncertainties, but I think our starting point is that we would be looking to mitigate all of those pressures to work within the funding envelope as it is around 2.5 billion in consequentials.
Emma Harper.
Thank you. And the Scottish Government has said that appropriate additional costs arising from COVID-19 will be met by the Scottish Government. Can you help us understand, Minister, what would be appropriate expenditure and how will that be met, or what would the additional resources that health boards and integration authorities be, I guess, expected would be appropriate, and how can we be clear on what funding will be approved as additional COVID-19 funding?
Minister.
So that's quite a big question, but I suppose the short answer is that appropriate expenditure is a range of costs that relate directly to boards or IJBs needing to respond to COVID. So that's I guess that's the kind of wraparound. I mean, I guess examples would be PPE, where they've had to employ additional staffing, beds, loss of income. So all that would be the sorts of things which would be appropriate expenditure.
Emma Harper.
Thank you. Just a final question, Convener, is health and social care partnerships and local authorities and health boards obviously are all working together flat out, and we've seen some really great practice and inventive aspects of changing their models of care and their approach. So, and I'm sure prioritisation is something that's on everybody's agenda, and it might not be that we talk about certain priorities right now because we're in the middle of a pandemic, but it's something for potential consideration in the future. I'm sure that the government's working with all the agencies to look at how do we manage the best model for spending in the future.
Minister.
Yeah, you're absolutely right. I mean, I think no one would have wished COVID on the planet, but it has shown the best in us all. So I think, particularly in terms of partnership working, there has been a huge re-engagement and partnership working across all of the systems, and that will help us inform some of the things that we might want to do going forward.
Thank you very much. Before I call the next member, Minister, could you indicate what methodology is being used to allocate the tranche of funding to health boards thus far, and whether the same methodology will be used for future? Minister.
Yes, so I mean, obviously historically funding had been by NRAC, but we're moving to an NRAC hybrid approach. So while NRAC is the basis, clearly there are times when allocations of spending need to be out with formula are particularly appropriate because of different particular pressures. So a hybrid of NRAC and funding out with NRAC.
And is that a finalised methodology, or is that?
I think that's likely to be where we're going, and clearly, obviously, there's the uncertainty is around where there is the need to go out with NRAC, and that is obviously based on evidence that we're working with boards and integrated.
Okay, thank you very much. I now call David Stewart.
Thank you, Convener, and good morning, Minister and Mr McCallum. I have a number of questions on social care, and you may have touched on some of these answers in your opening statement. In fact, the Convener kind of stole my thunder with some of his previous question. But nevertheless, I'll move on to a couple of questions I think that are important. Could you explain to the committee what scrutiny arrangements are in place in respect of additional health and social care spending?
Minister.
So scrutiny is, I think, really, really important, and it's something that we have to do on a shared basis. So scrutiny from ourselves in the ministerial level, and also through the boards. The funding method for social care is like what we have for health boards. It will be a a bit of a formula, so similar to NRAC, but obviously slightly different in terms of local authority aspect of that, but also some of costs based on actual costs. So part of the work that we have to do is to make sure we understand what that actual spend is. So there's a huge amount of work going on with IJBs and providers to confirm what the actual and forecast spending are for social care. And we don't have all of that information in yet, but that's the way that we're going, is that looking at actual spend and forecast spend, and we're working in partnership with boards and IJBs.
David Stewart.
Thank you, Minister. And my final question is, we obviously don't know about the details of the statement from COBRA or from the First Minister yet. But if we make some assumptions, we've all looked at the R number, where I think all the committee and the public are very concerned about COVID-19. Assuming there's a deterioration and there's a strictening of the conditions around how the public should behave, clearly social care is going to be an absolute vital tool in this. So in that basis, you've mentioned earlier there will be some further sums going towards social care. Are you able to utilise the contingency funds or contingency budget in the future if we need some emergency extra help for social care as a vital part of our COVID-19 planning?
In short, yes. We obviously need to understand what the needs are, and we're working with COSLA and IJBs to understand the levels of funding that are required going forward. Clearly, again, I can't give numbers just now because we just, part of your question just highlighted the uncertainty of what is happening, and some of your question was assuming this happens. Well, so we actually don't know what's going to happen, but we absolutely have to work with COSLA and IJBs to understand what levels of funding are required and would therefore be appropriate for an area which is of a priority to us all.
Thank you very much. And now call Sandra White.
Good morning. I want to ask some questions about the budget process, and I know that in its PPE as well. Now, I know that Scottish Government has been successful in sourcing PPE both at home and abroad, and obviously we're working on manufacturing more PPE in Scotland, and that is a really good thing. And you also mentioned the extra monies that's coming in the autumn budget for health. But I just wondered, going slightly back a bit in regards to the budget just now, how much has the Scottish Government actually spent to date for this budget process regarding Barnett consequentials? And has it been sufficient, the money that came from Barnett, has it been sufficient to cover expenditure in the area of PPE?
So, well, first of all, touching on the point you made about sourcing PPE from Scottish manufacturers, I think there's a particularly good news story. Prior to the pandemic, as I understand, close to 0%, if not 0%, of PPE was sourced from Scottish manufacturers, and around 49% of PPE is now sourced within Scotland, and excluding gloves, that's over 90% being sourced from Scottish manufacturers. So that's a really good news story, and probably worth highlighting. In relation to spend on PPE, so far to date, the figure I have is someplace between 170 and 200 million has been spent on PPE, with approval for a further 113 million. And clearly, obviously, we don't have a crystal ball, but looking forward, we need to make sure that we have appropriate stockpiles going forward for that. In relation to the Barnett consequentials, all of this is really challenging in terms of costs, and clearly we can't spend money twice. But there is no question that the government and I think all of our partners understand the importance of our frontline NHS staff having and social care staff and other key workers having appropriate PPE. So that's why it's really good that we now have, we're no longer reliant on the global market, which was a real challenge.
Yeah.
We drove up prices, and we now are able to source much of that in Scotland.
Thank you, Minister. And basically, that kind of touches on one of my other questions I was going to ask. When you mentioned it's pleasing that, obviously 49% is now sourced from Scotland, PPE, and obviously, as you mentioned, gloves, it's now up to about 90%. So the question I wanted to ask was, PPE was needed, social care and hospitals, etc., as well. So the speed which the virus, spread through and the need for PPE, did that influence the options available for sourcing PPE? Was it difficult at first until we got the manufacturing, or was it?
Well, obviously the challenge was that with a global pandemic, everybody was looking to access those stocks, which is why when it became clear that the social care sector were not able to access PPE stock through their normal routes, that the government stepped in. But there's no question that we will, I think, want to have a higher scale of PPE stockpile going forward.
Thank you. I'll try and put the last two questions together, because you mentioned the social care and obviously the stocking and the sourcing for the social care sector. I know you mentioned, I think, to Dave Stewart previously about working along with COSLA and IGBs. Is that how the sourcing and payment for PPE has been managed? Have you worked closely with them? And have they been effective and efficient? And then the last question I'm going to ask, added on to that, is what do you think the ongoing cost of maintaining adequate supplies of PPE is expected to be?
Well, obviously, in relation to the PPE for social care, that's been provided through the local delivery hubs, and that looks like it's going well. We need to obviously look at what we would do in a longer term. That was something that we set up specifically for the current pandemic, and we need to look at how we do that going forward. But there's a huge amount of ongoing engagement with the social care sector, the PPE steering group, COSLA, Scottish Carers, Coalition for Carers, whole load of partners that we are working with to make sure we have appropriate stock and that it is accessible to the folk who need it. In terms of, was the question about, was it cost?
How much? Yeah. Well, basically the ongoing cost of maintaining, adequate stocks of PPE. If you've got an idea what it might be expected to be.
So I think it's probably too early for us to give a figure that is really meaningful to the committee, but that's something that's under constant review with NSS, National Services Scotland, and but it's absolutely key that we have appropriate stocks, particularly as we move into the winter period and beyond. But that work is ongoing to understand all of that.
Thank you, Convener.
Yes, George Adam.
Thank you, Convener, and good morning, Minister. I would like to ask Minister about community hubs, because the summer budget revision identified spending of £35 million on community hubs, which was established to provide frontline community response to those affected by COVID. Now, they were set up in a way to take the pressure off of GPs and hospitals themselves. And as a committee, I think we're quite interested in these new ways of working, to seek as we'd like to see, is there better ways that we can work in future? And in the evidence to the committee on the 11th of August, Eleanor Mitchell, Interim Director General of Health and Social Care at the Scottish Government, said, and I quote, "Community hubs are likely to feature in our future as part of our reshaping of access to unscheduled care." Now, you understand how that seems to us in the committee quite an exciting thought that we could be looking at different ways to work. And my question would be, do you have any evidence that can be provided on the effectiveness of these community hubs?
Minister.
So, I mean, I think in terms of effectiveness, your final question there, I think there is good evidence that the establishment of the hubs and that that diversion of suspected COVID cases allowed our GPs to remain open going forward and accessible at the forefront, albeit often via digital technology. But I think if we hadn't had those hubs and that significant number, I'm trying to see if I can find the numbers of people, but I can't find it off the top of my head. Sorry, no, I can. It's 141,000, over 141,000 consultations have been through those hubs. And if that had to go through the GP system, then that would have been very, very challenging. So I think the fact that in the main, although in a different way, the GP practices managed to continue, with out of hour service, etc., and near me being and telephone conversations. If it wasn't for the community hubs, then I'm pretty certain that wouldn't have been possible. So yes, I think the substantive question, I think boards have retained the hubs and will continue to do so for the foreseeable future. And I think we want to look at what we've learned from that for the longer term in terms of whether there are lessons about how we provide primary care. We're already shifting primary care away from always assuming you go to the GP to a range of providers, pharmacy, opticians, etc. But going forward, I think there will be lessons from the hubs about what more we can do.
George.
Thank you, Convener. That's interesting, Minister, because one of the questions I was going to ask was, of these 141,000 the consultant people who consulted the hubs, of them, what do you have any evidence, or do you believe that had a massive impact on GP workload? You hinted at it there, but I just wonder if you had any more detail on the fact, and if you don't, if you could supply it to us, the difference it made to GP workloads.
Minister.
I think currently that would be difficult for us to get that data together, but I think because that'd be data we'd have to get from GP. So I think that'd be quite difficult to get. But I think the fact that GPs managed to continue and that huge, significant workload, over 141,000 consultations, was able to be diverted away, has got to have protected the ability for general practice to continue to provide a service to their patients.
George.
Thank you, Convener. Minister, my final question would be, what would the implications be for future funding of primary care if we did go down this different way of working in order to spread? Because you'll be aware the committee had an inquiry last year on primary care and how we deal with it. And a lot of the things we came up with were ideas on how do we think clever, how do we deal with everybody that's walking in off the street quicker, better, and ensure they're guided through the system. So what do you think the implications for future funding of primary care would be if we went down this route?
Part of that question was a longer term future, looking into the crystal ball almost type question. But what I can say is right now, these are separate arrangements. So right now, the funding of the hubs doesn't impact on the funding for primary care. They're separate contracts. But clearly, if this is something we're doing in the long term, then that would be something we would need to consider in partnership with our primary care partners.
Thank you very much. And I call David Charles.
Good morning, Convener, and good morning, Minister. Minister, with the potential for a second wave, is the Louisiana Jordan still able to fulfil its original role if needed?
Minister.
Yes, so obviously we've extended the period for the contract was initially 5 months, so we'd have finished in August. So we've extended that, I think, to 13 months. That takes it until the end of April, so it is still there and ready to operate. Clearly, we've looked at how we can use the hospital for other purposes to help us in other areas of the NHS, but clearly we're obviously all working really hard to try and make sure this doesn't happen. But if there were to be a significant second wave, then it's important that we have the hospital there. But clearly, the First Minister's statement this afternoon in the COBRA meeting that's going on and work across the UK, across the nations of the UK, is all about how we can protect the NHS from that kind of pressure. It's important that we have the hospital there as a stopgap.
David Thomas.
Minister, what are the ongoing costs of running the NHS Louisa Jordan, and is this a good example of pandemic planning by the Scottish Government? And over what timescale is the NHS Louisa Jordan expected to be kept operative?
So right now, the timescale is 30 months until the end of April. Let me just check for the figures in terms of the running cost. Yeah, okay, so the running costs are just under 2.4 million. That's obviously in addition to the setup costs, which were just under £31 million. These seem big numbers, but clearly, had we not managed to control the pandemic the way we did, and had the numbers in hospital risen the way we feared that they might have, then it was important to have that ability available. And likewise, while we have to continue to do everything to control this virus and protect our NHS, it's important that we have that extra capacity should it be needed. We just don't want to go back to the days of the First Minister having to read out double, triple figure numbers of deaths.
Thank you very much. For clarity, Minister, is that 2.4 per month?
Sorry, yes. Monthly running cost, yes. Sorry.
Thank you very much. I now call Donald Cameron.
Thank you, Convener. My questions are around a second wave, obviously, which is much in the news. Can I ask, firstly, what funding specifically has been made available to support preparations for a potential second wave in the weeks and months ahead?
Minister.
So there is a huge amount of work ongoing. I don't think I can give you specific numbers, and so perhaps, unless, Richard, are you able to help me with the specific numbers about?
Richard McCallum.
Yeah, I mean, I think there's maybe 3 points to this. So firstly, there's been no confirmed additional funding for a second wave from a UK government level in terms of consequentials, albeit we've had indications of our overall funding envelope for the remainder of the year. So part of this will be ongoing discussion about funding with the UK government. Secondly, I think as Mr. Fitzpatrick's already indicated, we have had confirmation of consequentials of 2.5 billion. So the first point will be making best use of those consequentials for a second wave and planning for that. And then the third element is, again, as Mr. Fitzpatrick has commented on, is making sure that we get that money out to health boards and partners, IJBs, as early as possible, so that they can make the necessary plans for winter and beyond.
I'm sorry to say this, but I don't find that answer entirely satisfactory, because this isn't just a question of consequentials. Surely the Scottish Government must have made plans for a second wave, and part of that planning must involve some kind of financial assessment of what's needed. So can I ask again, what specific, in terms of numbers from Scottish Government funding, what funds have been at least assessed as being necessary to support a second wave, which, if truth be told, we've all accepted is a distinct possibility, and we've accepted that for some time?
So work is continuing to be ongoing, to look at what would be required in a whole range of scenarios. We're working both with NHS boards, local authorities, and right across the sector to make sure we have as many of these plans in place as possible. Part of that, of course, is our winter planning programme, which has been established to coordinate across the health boards and social partners. So, one example of work that we're undertaking is the largest flu vaccination programme that Scotland has ever seen, working, of course, alongside our partners in the UK, who are also starting on the largest flu programme that the UK has ever seen. And that's all about how we keep the pressure down. But I absolutely think our priority has to be, well, it's absolutely right that we continue to plan and work as best we can to utilise the funds that we have. There is a responsibility on all of us to do what we can to protect the NHS and try to avoid that second wave pressure landing on NHS boards in a way which is really challenging. But the work is ongoing with NHS boards and right across the system, understand what might be required within a range of scenarios. Right now, we need to do that within the funding envelope that we have in Scotland. Clearly, if additional funding comes through further consequentials, then we'll be able to look at how we use those also.
Donald Cameron.
I don't deny anything that the Minister has just said. I just find it extraordinary, and I accept that he's standing in for the Cabinet Secretary. But I do find it extraordinary that a figure cannot be placed, at least an estimate figure cannot be placed, for what Scottish Government expenditure might be on preparing for a second wave.
I just at the end of the day, I don't have a crystal ball. The Scottish Government doesn't have a crystal ball. Everything we are doing is to try and use our magic wand as best we can, which is the public and all of our services to work to minimise any dangers of a second wave, to try and make sure that doesn't happen. And that's why there's a COBRA meeting happening just now. There's no politicians, as I understand, anywhere across these islands is able to give you the number that you're asking for. So Matt Hancock can't give you that figure because none of us have got a crystal ball. So I'm sorry I can't give you the answer you're hoping for, but I think it's probably because the answer doesn't exist. But what I can assure the committee is that work is going on to look at a range of scenarios and make sure that we are planning as best we can for all of those going forward.
Final question in this area from Donald Cameron.
Thank you. My question, if I can move on from funding, can I ask about, there are obviously various indicators that can be used to represent a second wave. That might be infection rates, it might be the R number, it might be admission rates to hospital, it might be admission rates to ICU. What in the Minister's view represents a second wave? And in addition to that, at what point would any increase in the various indicators mean that we might see a cessation, say, of elective treatment in that we're returning to kind of a lockdown or a semi-lockdown?
Minister.
So I'm not sure if you watch if committee members watch the First Minister's daily briefing, but earlier, either the end of last week or earlier this week, I think it was last week, Jason Leitch was asked roughly this question, and he answered it by suggesting that in an ideal world you would have effectively a dashboard of all of those indicators that Donald Cameron mentioned, and while if all of those indicators are low, then you can easily say everything is green, and if they were all high, it would be easy to say things are challenging and we're moving into a second wave. Clearly, the real world doesn't work like that, and it's likely to be a judgment based on a range of those factors, and that's judgments which the First Minister and advisers are making on a daily basis, looking at all of those figures to understand where we are going, and I'm pleased that today that is happening on a Four Nations basis to some extent, so that the COBRA is able to make sure that ministers across the UK are able to look at that evidence together and to see whether there is a common approach possible.
Thank you very much. I call Sandra White.
Minister, I just wanted to carry on from funding question in regards to if there is a second wave, and I just wonder if the Scottish Government has the figures how much has been spent on testing to date.
Just on testing, again, I don't think we have an exact figure, but I think it is operating within an envelope of the consequentials of 136 million. So I think it's currently within that figure.
Okay, thank you. I just thought I'd ask that question because obviously we're looking at if there is a second wave, and you've already mentioned the fact that nobody has a crystal ball, so we don't know how much funding is expected, but I'm sure the committee may write to yourself or CABSEC to see if we can get further updates on that particular one. Now, there's been talk about testing and what measures are being taken to address what has been said as people not being able to get tested, although I did note that the fact that the Lighthouse Lab in Scotland, in Glasgow, is the most successful in the UK. It's well over 40,000 tests have been done. And I think if anyone has looked at the graph, I think it was in the Times newspaper, we'll see that Scotland is at the top for the testing. So I just wondered how you would address the issue that some questions have come forward in regards to pressure that's being put on testing labs, and what measures are being undertaken to address these. Now, I do recognise that we are hoping to work along with, obviously, the UK one and also our NHS labs. Figures I've commented to you would appear to me to see that Scotland is pretty much at the top of the testing. So while some areas may be lagging behind, do you know what measures are being taken to address that? Somebody says that the comments were that there weren't enough people in the labs. So I just wondered, if you had any information in regards to some of these comments.
Thank you, Sandra. Minister.
Well, I guess there's not a league table as such. I think we're all trying across the Four Nations to do our best to make sure that the testing is available, that is needed, and that's the way that we are working with the UK government in terms of the Lighthouse Labs. There is huge pressure on that UK-wide testing programme, immense strain as demand continues to outstrip the capacity. So as you say, we're continuing to work with the UK government to continue to build pathways and to build laboratory processing capacity. So part of what we've done is sought assurances in relation to making sure that Scotland receives that Scottish share of capacity. But I think part of the issue is in relation to some of the growth in capacity that the UK government had planned is maybe not going as quickly as they had hoped. But we're all working together to try and improve capacity. And as you say, one of the ways that we're trying to help with that is to look at whether we can bolster the NHS capacity to take on some of that workload. But clearly we need to make sure that we still have access to our population share of the UK labs, and we're not like just ripping off Peter to pay Paul type thing. So we need to hope to make sure that there is an overall advantage to us in that work. But the range there's a range of issues, and we certainly are working very hard to make sure that capacity in Scotland meets the demand that is required, because it is very important that people can access tests if they have COVID symptoms.
Thank you very much.
I just come in and just...
All right, yes, Sandra.
Oh, sorry, thank you. Yeah, I just wanted to ask the Minister as well. Recently opened in Caledonia University is the ARC, which has been very successful, and people can phone up, make an appointment, and certainly in my area with Freshers Week and that, we've had a few people going along there to get tested. Is this the type of progress you're hoping to make with the UK government as well, obviously, that we'll have localised centres where people can just walk into rather than having to take a taxi or a bus or whatever?
Minister?
Yes, and now forgive me if I'm getting the exact number, but I think that's now 2 of these labs out of, I think, a predicted 20, maybe slightly more than 20, around 20 of these centres that we are expecting across Scotland. And so, yes, that is very much part of that increase in capacity, making sure that people can access testing when they have COVID symptoms. It's very important that people only go for testing when they have COVID symptoms, because I think some of the pressures elsewhere appear to be people getting tests when they don't actually have the symptoms.
Thank you.
Thank you, Minister. Thank you, convener.
Can I call Brian Whittle?
Thank you, convener. Good morning to the Minister and good morning to Mr McCallum. Can I ask around pandemic preparedness? I think we would recognise that we weren't set up and weren't prepared for the kind of pandemic that's now hit globally. Despite some of the initiatives like the Silver Swan initiative, that a lot of the recommendations weren't followed. In the Level 4 budget information, it shows that there's a £14.9 million for board resilience in 2020-2021, which is there to maintain that preparedness of the Scottish Government and NHS for an influenza pandemic. I'm presuming, Minister, there would be a higher level of spending now looking ahead on pandemic preparedness. Would we expect that that would be required in future years?
Minister.
So, in the light of the pandemic, I think the answer to your question is almost certainly yes, that the cost of maintaining a national stockpile and other medical supplies and equipment to deal with any form of future pandemic, not just influenza, is going to be higher than in previous years. We obviously, as I said in light to an earlier question from Sandra, one of the challenges at the start of the pandemic was that everyone was trying to access PPE at the same time, and in spite of stockpiles, we had to access, the only orders we could do were international orders. We now have a significant capacity for PPE manufacture in Scotland, so I think part of our long-term planning will be to look at how we can sustain that here in Scotland to make sure that we're not competing with the whole world when we're trying to buy PPE in any future pandemic.
Brian Whittle.
Prime Minister, I think you highlight PPE, and of course we have quite rightly have addressed that issue in terms of ensuring that we have access locally to PPE. We wouldn't be caught the way globally everybody was caught with everybody scrambling for the same products. But of course, it's not just about PPE, it's about how we structure our NHS, how we structure our health service to ensure that that preparedness for the pandemic is there. So can I ask, in addition to that, where the additional funding, or what additional funding would be expected to require in future years, and how the NHS is being structured to cope with any future pandemic issues?
Minister.
So I guess the first point is that we're still in this pandemic, and today's and the events over the weekend show just how real that is. But long term, we're committed to ensuring that health and social care services in Scotland have access to the type and level of equipment and medical supplies required to combat any future pandemic. There's no question that this pandemic there'll be a huge amount of learning from this pandemic. Clearly, I guess in the past we'd always assumed that to some extent that any pandemic would be something like flu, and clearly there are significant differences in COVID-19 compared to what's required for a response to a global influenza pandemic. So I guess that's part of the learning that we'll all be taking. But priority now is dealing with the current pandemic, but you're absolutely right that going forward we need to ensure that our health and social care service has the correct resources and that we learn any lessons that we can from this pandemic to help influence future pandemics. Clearly the lessons from this pandemic won't just be about planning for future pandemics. There's a number of things where we've I think, learnt to do things differently and at a different pace than we probably previously thought was possible.
Thank you very much. I call again George Adam.
Thank you, Convener, and hello again, Minister. I'd like to ask about service innovation. It's almost connected to my earlier questions, but when we've been going through the budget process here on the committee, we've heard from health boards and IGBs that have said that the pandemic, this worldwide pandemic, has actually made them look at different ways of working. Now, one went so far as that this was the main reason. Now, one of the things that comes to mind with me is the fact that the Scottish Government have been pushing this agenda for some time. Why has it taken a worldwide pandemic for many of these partner organisations to finally look out with their silos and deliver services different? And also, I would like to see, even we've got some evidence here from Vicky Irons, Chief Officer of Dundee Health and Social Care Partnership, which you'll probably be quite aware of, Minister. And she said that the first principle of Dundee's IGB's remobilisation plan is that people will attend buildings for assessment and treatment and care only when there's no other alternative is available. This is because we're still in a period of risk around people being in closed spaces, but it is really an indication of what we should be striving for in terms of our provision of care in the future. And again, it goes back to what I asked earlier on, surely when we've been going through this difficult time, surely these new ways of working should be continued with health boards and IGBs. 9 times out of 10 it was IGBs that were put to the side and the health boards were carrying on forward. But surely this is a better way, because it's got to be patient-centred and it's got to be the patient that's important, not the structure.
So I think prior to the pandemic, there was almost certainly resistance to moving to some of these new ways of working, such as Near Me, not just from patients, but also from service providers. Because of the necessity of the pandemic, I think we have seen that go away, and folk have all of a sudden realised the real potential of some of these new ways of working. Clearly, Near Me is probably the biggest example and the easiest example for me to talk about. We had planned those changes for Near Me, or we expected it to take around 2 years to deliver, and we managed to deliver it because of the pandemic in 6 weeks. And I think if you speak to people, patients, GPs and others who prior to the pandemic would have said that won't work, I need to see all my patients face to face, or no, I need to see the doctor directly, I don't think people will want to go back in terms of the huge range of benefits of GPs being able to see people more efficiently, patients being able to take effectively 15 minutes for a 15-minute appointment rather than the time travelling to the GP surgery, for instance, sitting in the waiting room and then going back to work. So there's a huge number of benefits, and I think I don't think we'll go back to the old ways. And I think what people will realise is actually we need to try some new things. We might not think it's a good idea, but sometimes we need to just try it, and we might be pleasantly surprised, as we have been with Near Me, for instance.
Thank you, Convener. On that point, Minister, I think you make a valid point there, in so much as patients don't really care how they navigate the health service, just that as long as they're dealt with and they find a way through the navigation of the health service. And one of the questions I've probably follows on from this. Do you think that the reliance of hospital-based care in the future is going to be, there's going to be less of that, and are there positive lessons that we can be learned through the pandemic on how we can retain some of these new innovative ways of working?
Minister.
Yes, I think the importance of shifting the balance of care is clear. It's something I think we've been trying to do for a considerable length of time. So in summary, yes, I think the points you make are absolutely right.
George.
One final question, and it's, it was basically a lot of people have been working from home during the pandemic, and obviously not every employee of a health board or IGB is front-facing, patient-serving, at the front line effectively. So do you think there is scope for some other members to have more home working as a part of the health boards and IGBs in the future? And if there is, do you think that would have a knock-on budgets in the future and the idea of the centralisation of office-based functions? So effectively you wouldn't necessarily need to have offices in certain sites in the NHS throughout Scotland if you embrace this for the future?
Minister.
So I think that is something that not just boards but all employers should be considering. Really important now in terms of the pandemic to help stop the transmission of the virus. But going forward, there's huge benefits in terms of our climate change agenda as well, and it's becoming easier to do. So yes, I think it is something that boards should be considering. We have Office 365 and other IT products that are in place, which NHS boards have in place. But I think that needs to go wider. You mentioned IGBs, and so it should go to there. Clearly, there are some times that people need to be at their work, but roughly half the committee are in the Parliament just now, and the other half are working from our homes. So it kind of shows that we all are able to work differently, and we're becoming more adept at doing so. In terms of costs around that, there's a fair bit of work going on, and I think you mentioned savings. Fair bit of work going on to evaluate the costs of all that, but I don't think it's necessarily about savings. It's about spending the right money in the right place to make the health difference that individuals want to see.
It also helps the quality of life of staff as well, Minister, giving them more balance in their own personal life.
Indeed.
Thank you very much. And we'll move on to consider financial stability of health boards and start with David Truffles.
Once again, Minister. Would the Minister anticipate needing to provide ongoing financial support to 4 boards that have received additional funding in 2019-2020, aside from any COVID-related support?
Minister.
I think it's too early to say. Obviously, we'll review that over the course of the remainder of this year, but I think it's too early to say.
David Truffles.
Will the in-year support require to be repaid, and if so, over what is the timescale?
Minister.
I guess this goes back to the question that Emma Harper asked earlier, but where there are clear COVID-related additional costs, they will not require to be repaid by health boards or integration authorities.
David Truffles.
Does the Scottish Government anticipate that the boards requiring in-year financial support will be able to achieve a break-even position within 3 years?
Minister.
Well, that should be the target of the boards, and that relates to, but clearly we need to understand the impact of COVID.
David Truffles.
And my final question, Convener, how will the coronavirus pandemic impact on the ability of boards to break even over 3 years as required by the Scottish Government?
Minister.
I'm sorry, I feel like I'm a little bit of a broken record here, but it's I think just too early to give a clear position. But because we just won't fully know the long-term cost implications of COVID at this stage, so that would be particularly challenging. Apologies that I can't be clearer on that.
My question is perhaps for Richard McCallum. Because the Cabinet Secretary previously indicated that the development of the 3-year financial and savings plans was paused at the outset of the pandemic. Can I ask Mr McCallum, has the planning been resumed as yet, and what assessment can be provided of the impact of COVID-19 on financial planning? Richard McCallum.
So the financial planning has been very much focused on the in-year position and making sure that we understand the full costs of this year. And I know you've heard as a committee from Ayrshire and Arran and from Glasgow and from Lothian about that. And so we're obviously having those discussions with the health boards about their immediate financial plans. What we'll now be undertaking in view of an up-and-coming budget in December will be to look at these longer-term financial plans. As the Minister has said, there's a lot of uncertainty about the future and the likely costs, but we're starting to build that picture up with health boards now, and that will give us the kind of indications of what will be required over the next 3 years, and it would still be our intention to have that longer-term 3 to 5 year financial plans in place.
Thank you very much. That's helpful. And can I now call Donald Cameron?
Thank you, Convener. On a similar theme, in terms of longer-term financial planning and structures, in October 2018, the Scottish Government set out its medium-term financial framework, health and social care, and at that point, identified the need for savings of about £1.7 billion over the period 2016 to 17 through to 2023 to 2024. Obviously, a lot's changed since then, but given that was the position pre-pandemic, can you tell us when the Scottish Government might be in a position to update the medium-term framework that will reflect the impact of the pandemic?
Minister.
So I guess we're still in the pandemic, so it's difficult to understand when we'll be able to get the lessons from that to feed into that. But I guess that's something we can write to the committee when we have that information.
Donald Cameron.
Does the experience of the pandemic suggest that we'll see a shift towards a more centralised control of resources in terms of health and social care?
Minister.
Well, I guess yes and no. So in the short term, for the immediate pandemic response, then clearly, that is the case. But however, as the system responds to the impacts of COVID, local recovery and redesign is going to be key going forward.
Thank you very much. We'll now move on to the questions around integration, which is an ongoing issue for the committee, and start with George Adam.
Thank you, Convener, and once again, hello, Minister. I think you, Minister, you feel as if you're repeating yourself quite a lot during this. I feel I keep repeating myself because all my key subjects have been about how we can work better and how an integrated model might be the way forward. And this, obviously, section I'm talking about is the integration model during the pandemic. And again, the pandemic presented both opportunities and challenges for the operation of integration. But the committee, as the convener already said, has got quite an interest in this because they've highlighted the slow progress that had been made towards achieving integration and the persistence of silo mentality in a lot of the organisations and partners involved, and that social care money continued to be treated as two distinct pots of money, rather than losing their identity as intended and be seen as how do we solve the problem, not so much individual organisations seeing it as their own money. Now, one of the questions I would like to ask initially would be, the Scottish Government's Lessons Learned report highlighted both the positives and negatives that I mentioned for integration through the pandemic. Does the Minister feel that the system has responded well to this, or have the known challenges been exposed?
Minister.
Gosh, that's quite a wide question. I guess rather than giving you my thoughts, maybe give the thoughts of some of the partnerships, because I think what we're hearing from the partnerships is a view that what we've achieved through the pandemic would have been much more difficult without integration. And the closer partnership arrangements that have built up over recent years under integration between managers, professionals, health and social care have been particularly valuable in helping us to be more rapid in our response and more agile. So I think the joint working practices that had been developed before have helped, but clearly with the pandemic we've accelerated that process of integration and folk working together and looking at the bigger picture rather than, as you mentioned, silos.
Georgia.
One of my concerns, Minister, is that there's all these experiences and all these examples of how things have worked here now when we're at the coalface and things have been really difficult, and nothing brings out the best in people than a challenge of this magnitude. But one of the concerns I have, and it was when I was listening to organisations like, in my own area, NHS Greater Glasgow and Clyde, they say they've brought in all these new structures, there's ways of doing it, but it still sounds as if they're talking about working from the centre. And is it not the case that with these new structures and new ways of working, it's the patient that should be the one that's the most important here, and the decision making should be made on the patient's way through the health service and social care, as opposed to this reliance and control from the centre? Because my big fear is we end up everything when and if we get through this, we just revert back to normal again. And we do have some experience of health boards that have done things like that in the past, just go back to their old ways of thinking and working.
Minister.
So I think most of your question was actually just a matter of fact, and I would concur with the point that you were making within that. On the point of that suggestion that we might revert to normal, whatever normal is, I think it's really important that we make sure that we are learning from all of the best practices, and so that work is going on, and there's some really good examples of best practice in terms of how integration is working from various parts of Scotland. I have examples here, but I know the committee's time is tight. But my main point would be it's really important that we make sure that we don't lose that, and where things are particularly good, we don't just hold it for one area. We make sure that is shared across the system and effectively in a Once for Scotland approach going forward.
Georgia.
Thank you, Convener. Thank you, Minister. If you could send that information on to us about examples of where it's worked and how well it's worked, that'd be interesting for the committee's ongoing work. But one of the concerns I have is, do you believe, Minister, that partners have been represented equally in the decision-making through the pandemic? Because that hasn't been the case in the past with some partners, particularly IGBs and various social care element of it put to the side.
Minister.
So I guess I'm just talking from my experience. I think people have learned very quickly that we are all in this together, to take a little bit of a cliche and to look at the bigger picture, which is, as you say, the patient and making the patient centre of decision making. So I think good progress has been made across a range of areas in terms of that patient centred approach.
Georgia.
No, thank you, Convener. That was my final question.
Thank you very much. Brian Biddle.
Thank you, Convener, there. Minister, a repeated theme of committee inquiry work has been around about the integration or should I say the lack of progress towards a financial empowerment of AJBs. I think the Ministerial Strategic Group did highlight what George Adam raised there, that there should be a focus on outcomes rather than the public body which put the pound in the pot, and that, as our inquiry highlighted, not necessarily happening. I mean, the guidance suggests that that key aspects of governance and accountability between partners has previously been largely unrecognised, and the effect of that is a lack of transparency, governance and accountability for the integrated functions that are under the control of the IGB. So can I start, Minister, by asking if you consider or recognise that there is an ongoing issue in relation to the financial empowerment of JBs around the way that individual partners continue to influence the allocation of resource?
Minister.
I think that's not been my experience. So, I think certainly through the pandemic we have seen partners working across the system in a way that we would have all said is what we wanted before. So, I think the pandemic has shown the best in all partners working across the system.
Brian Biddle.
I would, with the greatest respect, Minister, I would ask you to have a read at some of the inquiry notes that have come out from the committee that suggest otherwise, although I do agree with you that the pandemic has actually forced the issue, and to some of George Adams' questionings, it just seems that it's taken a global pandemic to sort of force those that sort of collaborative working. But can I ask you, how the directions being used by the IGBs to ensure that resource are used in line with the government strategic commissioning planning, and how are you measuring that in effect?
So direction is an interesting one, and clearly direction should be used when it's required, but I think evidence would suggest that strong evidence of good partnership working is actually key rather than directions. But it's appropriate that directions are used where appropriate as part of that process. But I think if partners are learning anything through COVID, it's that building those strong relationships and strong partnerships is what is helping us deliver for the person who's at the centre of whatever service it is we're providing. And there's good examples of that.
Brian Biddle.
Finally, Convener, I think the Minister, you highlight that that there is good practice out there among certain IGBs. So I think that I would ask how the government ensuring that good practice being shared across the whole of the country, and how might we make better use of that good practice and directions of the IGBs to improve that transparency, governance and accountability that has been highlighted within some of the committee's inquiry.
Minister.
So one of the important bodies that has been set up recently and ongoing is the Ministerial Recovery Group. So that is pulling together partners, not just from government, from across government, but also from a range of IGBs, health, range of partners, including trade union representatives and others, pulling them all together to make sure that we're as we develop the recovery going forward, that we are hearing all of that experience going forward, and we're doing that with as much evidence and base as possible.
Brian Biddle.
Well, that was my final question. Thank you, Convener.
Thank you very much. Emma Harbour. sorry, just one moment until we get the sound. There we are. Emma Harper.
Thank you, Convener. Sorry for talking over the delay. Just a couple of questions. One's about set-aside budget and the other one is about a longer-term shift of the balance of care. You've talked already in response to George Adams' question about service innovation and new ways of working, and shifting the balance of care is part of that. So can you confirm, Minister, if we expect to see a longer-term shift in the balance of care between hospital and community care as a result of the pandemic? And obviously the pandemic has caused like a rapid shift in some of these innovative services leading to the transfer of care.
Minister.
Yes, so we have, I think, been making good progress to deliver. The target is to deliver more than half of our spend in community health services by 21-22. So the baseline for that in this Parliament was 47.7% at the beginning of the Parliament, and that increased to 49.7% in 2018-19, and the committee will be aware that the budget for this year set out a further shift in the balance of care. So we're making good progress. Obviously, we'll see the figures coming in going forward, and I'm confident that the work that we've done in this year will show that continuing to shift. In terms of the impact of set-aside budgets, during COVID, the primary focus has already obviously been making sure that the person who needs the care gets the right care in the right place at the right time, the point which was made by both Brian Whittle and George Adams.
Emma Harper.
So in regards to the set-aside budget, we've heard in evidence that it's often, the set-aside budget is often treated as being under the control of the NHS board rather than the IGB. And that means that there's a result that it's difficult for the IGBs to use the money to implement preventative services. We've heard a lot about preventative services in our social care, in our social prescribing inquiry, and how important, keeping folk out of hospital is as well. So I'm interested if you agree, Minister, with the findings of the Ministerial Strategic Group that set-aside budget arrangements might still not be working effectively, and if you think there are ways that we can improve the way that this budget is working or is assigned. I know there are health boards like NHS and Galloway that don't call it set aside in the first place. So to me, it means that it needs a look at it.
Minister.
So I think you're right that we don't actually have the full clarity, and it isn't yet clear to the extent to which COVID spend across the centre, across the sector, would have impacted on that spend. And I think the point you're saying that we need to look at that, then yes, we'll need to keep a close eye on that and make sure that there is transparency around that going forward.
Thank you very much. And David Stewart.
I have a few questions, Minister, on delayed discharge. In the Lessons Learned report, delayed discharge was described, and I'm quoting, to deep-rooted behaviour issues and, I quote again, lack of trust. What assessment has the Minister made of the report and the above no-holds barred comments?
Minister.
So it's really important that we continue to work with health and social care partners during the pandemic, and continue to look at reports like the Lessons Learned report to help guide us going forward.
David Stewart.
And again, just a follow-up, Minister. I mean, clearly there have been major problems in the structure of our Scottish Health Services about delayed discharge. And perhaps you could say that it's too early to learn the lessons, as I think you replied to George Adam about this. But have there been any lessons learned about delayed discharge, and have we managed it in the future post-COVID-19?
Minister. So clearly there will be further lessons that we'll need to continue to learn, but but there are certainly some really good examples of good practice that we can point to. I mean, what we have to remember is that the patients that we're talking about are people who no longer require to be in hospital, and I guess that's our primary objective is that they shouldn't be there. So there's some particularly good examples. Given the convener's local interest, one example that I would want to flag up is in Aberdeen City Council, where they utilised spare housing capacity to provide extra housing for care flats with a voluntary provider. So unused space in those buildings was quickly adapted to provide an additional 10 flats, and they also had 13 supported hospital discharge rooms in shelter housing. So, that could have been done before the pandemic. It wasn't. So there's an example of just working across the system to find a solution that works not just for Aberdeen City Council or for Grampian Health Board, but works for the individuals who are at the end of that. So clearly we need to look at all those examples and do our best to make sure that that kind of best practice is the normal rather than something that we just roll out in the pandemic.
My final question, Convener, is clearly all the committee and the minister is well aware of that, but certainly in evidence we've taken in the past, we all know the damaging effects that delayed discharge can have on vulnerable, particularly elderly people who shouldn't be in hospital. We, as we've said, perhaps slightly tongue-in-cheek, hospital's not a good place to be if you're unwell, is a slight inverted commas around that. But clearly we know the massive loss to muscle tone of delayed discharge, how that affects health and makes it more difficult. So my final question is really this: can the reduced levels of delayed discharge we have seen in the March-April figures be sustained or even eliminated altogether?
Minister.
My bottom line is we really need to make sure that is the case for all the reasons that you said. I think all governments have been trying really hard over the years to reduce the levels of delayed discharge for the reasons that Mr. Stewart mentioned, and we've now got to a position. So I think the whole system needs to work really hard to sustain that going forward.
Okay, thank you.
Thank you very much. Thank you very much, Minister. There's clearly much meat in all of that and many things to which we will return. I think there's a number of areas where you have made a commitment today to come back to us with more information. Clearly, we'll watch very carefully for the autumn budget revision in the next couple of days. But in the meantime, thank you very much for your attendance today and for dealing with such a wide range of questions. And thank you also to Richard McCallum.
Thank you.
Thank you very much. Thank you. And we will move into private session in a moment and resume on a different platform. So I now suspend this meeting and we will resume in 5 minutes' time. Thank you very much.